So, good afternoon, members. I am Dr. Rajani. So, we're going to first look at the clinical features and the diagnostic workup before we go into the management. Okay? So, just an overview to recap everything that we have had. So, empyema thoracis is common. It's actually very common, and it carries a significant morbidity and mortality. Okay? So, and the mortality is very high in the elderly population. So 75% of the elderly population, so you need to define what our elderly population are like, carries a mortality of 75%. And most common cause in our setting is it's a complication of parapneumonic effusion. Risk factors, there are several risk factors that you need to look at in your patients. Comorbidities like malignancies, underlying malignancies, be it hematological, be it lung malignancies. Other things like HIV, patients who are taking steroids, patients with diabetes are at high risk, patients who are alcoholic are at high risk, even patients who are smokers are at high risk because of other comorbid illnesses. And the other common cause risk factor is recent thoracic instrumentation, and most commonly in our setting that is a pleural tap or thoracocentesis. So patient may have a simple parapneumonic effusion. So what I mean by parapneumonic is patient has pneumonia, inappropriate antibiotic therapy, be it the inappropriate antibiotic itself, be it the inappropriate route, be it inappropriate dosage. Okay? Then parapneumonic effusion continues, the pneumonia continues, that progresses into an empyema. Okay? The other things are like when you do a pleural tap and it is not done aseptically, you can also cause a parapneumonic effusion that progresses into your empyema thoracis. So those are important history that you need to take. And many of these patients come with features of sepsis, which we are going to look at. So you need to differentiate what empyema is and what lung abscess. Sorry. So in your patients, you have to differentiate empyema from lung abscess. Okay? So for the undergraduates, it's important to know where lung abscess is and where empyema thoracis is. So empyema thoracis, the collection is in your pleural cavity. The other name for empyema thoracis is pyothorax, or pus in the pleural cavity. That's what it means. And lung abscess, basically you have an abscess with air fluid level in your lung field. So clinical features, most times it is non-specific in the history, but many times you will have a history of chest infection in these patients, okay? Say a pneumonia. So risk factors include lower respiratory tract infections, which is one of the most common. Trauma to the chest, it could be a rib fracture. It could have been a non-traumatic or traumatic rib fracture, so you need that history as well. And the other important thing is the recent thoracic instrumentation. So in 40% of the patients, you may have that history. So patients may complain of fevers, so features of sepsis, okay? Fevers, chills, they may be vomiting, reduced urine output, all that. So all those features of sepsis. And patients may be coughing, they may have pleuritic chest pain, and dyspnea. Now, the pleuritic chest pain, initially, the patients will complain that they are really painful, okay? And with time, you may see that the patient's chest pain improves. That's not because the patient has improved. That's because your pleural space is now more apart. The parietal pleura and the visceral pleura is wide apart because of the fluid collection. So as the disease progresses, the pain might be much less. So clinical evaluation, you will see a septic patient, a toxic patient, usually febrile. They may be tachycardic. They may come with hypotension if they have septic shock. They may also be tachypnic and what can I say, diaphoretic. Chest exam, they have reduced breath sounds on the side where the pleural effusion is suspected, and stony dull percussion note. And it's also important to note the percussion dull tenderness in these patients. So as you percuss, you will see that the patient wins, okay? And there are signs of massive pleural effusion like the shift of mediastinum, so the trachea is shifted. There might be hyperresonance on the opposite side because of hyperinflation of the opposite lung due to compensatory emphysema. And If the pleural effusion or the empyema continues for several weeks without treatment, appropriate treatment, you can have empyema necessitans, which is pus or purulent discharge through a sinus from the pleural cavity connecting to the skin. Okay, so they may have pus discharge from the skin on the chest. So that is what is called empyema necessitans. And some patients may have features of bronchopleural fistula. So they have purulent sputum, copious amounts, fevers, finger clubbing, all those stuff. And patients may also present with features of right heart failure or poor pulmonary. That is eventually in the disease where the fibrosis sets in. So you have a fibrothorax or scarring of the pleural cavity, restrictive lung disease, and right heart failure. And you can also have hematogenous spread from the focus in the lung, if that is the focus, causing splenic or brain abscesses. So investigations, mainly you have your blood tests. So we'll discuss what blood tests are necessary in these patients. We have the imaging modalities. We have pleural aspiration or thoracocentesis. There are microbiological examinations that you have to do, and then there are other tests looking for the risk factors like HIV serology, your blood sugar, and all that. So blood tests, complete blood count is important. Most of these patients are septic, so they will present with a neutrophil leukocytosis. Okay? They may also have other features of sepsis like high C-reactive proteins, and in case where you suspect TB, you may have a high erythrocyte sedimentation rate or ESR. Imaging, we have already gone through that. Dr. Christine has gone through it. She has described the chest radiograph findings. We'll look at the ultrasound findings, because ultrasound is one of the most sensitive tests in patients with empyema, especially in prognosticating and risk stratifying these patients. And then we already discussed the chest CT, how useful it is. So that is the chest X-ray. You have the empyema there with air fluid level. So there's some gas formation. Okay, it could be that it's iatrogenic. So if you do a thoracocentesis, you introduce some air. So some patients, the air fluid level or pneumothorax on top of the fluid could be because of iatrogenic pneumothorax. That's a lateral view. So chest ultrasound is one of the most sensitive tests for staging empyema, especially in knowing what stage of empyema it is, whether it has septations or fibrinous strands, because your management will depend on what stage the patient is in. For example, you can manage patients just on antibiotics, but there are patients who may not respond to antibiotics. They will need intercostal drainage or underwater seal drainage. Okay, there are patients who may be fine with underwater seal drainage, but there are others who will need, despite antibiotics and underwater seal, they will need cardiothoracic intervention. Okay, so we shall see which patients need those. And then there are also real-time bedside ultrasound, where instead of putting the blind underwater seal drainage, which we do, we go in blind without ultrasound guidance. In other world or other centers, you can do ultrasound guided intercostal drainage insertion, where if there are septations, you can put it in the appropriate space. And also for the ultrasound can be used to put the port sites for treatment using VATS. I think the cardiothoracic surgeon will go through the details. So that is the ultrasound image. So your probe is there. That is your, I think that is a spine sign. If I am wrong, the radiologist can correct me. I don't know if she's still around. Okay, so that is the collapsed lung, and that is the fluid. So those are all the septations. This is a septation. So that is the fibrinous strand. Because as the disease progresses, what happens, you have a lot of fibrinous strands because of increased proteins, proteolytic enzymes, and all those stuff. Okay, the same thing on this other image. That is also your fibrinous strand. So CT scan is very useful, especially to assess the size and location of your pleural fluid, and also to differentiate empyema from lung abscess. okay? And also to look at whether the patient has underlying lung malignancy or pleural malignancy, or if whether the patient has bronchopleural fistula. So it's important to see which patients would benefit from a CT scan. If you're not sure, it is best to have a CT scan so that it clarifies or gives more details. Now, contrast enhancement, like Dr. Christine has already explained, contrast enhancement is important because when your pleura is thickened, inflamed, it is going to enhance. And one of the images she showed, actually, there was contrast enhancement and pleural thickening with cortex formation. So most likely we may eventually call our cardiothoracic colleague here. And then there's what is called the split pleural sign, where at the margin of the pleural space, you have the parietal pleura separating from the visceral pleura, okay? And that is, it can be seen on a CT image. So that is the pleural enhancement. I don't know whether you can see slightly enhanced whitish. It is more whitish than the surrounding tissues. So that is the visceral pleura, and then you have the parietal pleura there. Now these are air bubbles. So that is gas formation because of the organisms. Pleural fluid aspiration and analysis, mainly for diagnosis and risk stratification. You need to look at the gross appearance. So it can be blood stained, it can be yellow, it can be green. That gives you the details as to which organism it could be, okay? It can be foul smelling if it is anaerobes. Gram stain will show you pus cells, and depending on the organism, it can be gram positive or gram negative. And then there's a biochemical analysis of the fluid, which will give you details to the pH, LDH, proteins, and the glucose, which are very important. So that is how you will characterize your pleural fluid. A simple paranemonic effusion, complicated versus empyema. So I think you will go through it. For a simple paranemonic effusion, your pH is greater than 7.3, and more bacteria, your pH reduces. In other words, your pleural fluid becomes acidic, okay? And the bacteria consumes all the glucose, so your glucose goes down, okay? Your LDH, which is an inflammatory marker as well, goes up, okay? When you have complicated paranemonic effusion or empyema. And the neutrophil counts are over 10,000. Your microbiology gram stain and culture may be positive in complicated paranemonic effusion or in empyema, unlike the simple paranemonic effusions. So that again gives you some of the details which you can read, and that's a pathophysiology of how empyema is formed. So initially you have clear fluid because of the cytokines, the interleukin A, TNF alpha. You have increased vascular permeability and increased interstitial fluid, causing your serous pleural effusion, okay? As time goes by and you have bacterial invasion, you have more phagocytosis and lactic acid production, and glucose is utilized. Your pH goes up, your pH goes down, you become more acidic, your glucose reduces and your LDH increases. And when you have empyema, it is frank pus. So those are some of the organisms that are commonly responsible, mainly Streptococcus, Strep pneumoniae, Staph aureus. Now this is a UK study. I don't know whether we have figures from our microbiology team. We haven't seen any. I looked for some, but I didn't see any. In the adults, you need to look for Staph aureus as well, which is one of the common organisms. And now certain TB is a common cause. So staging, I think you can read that the different stages of empyema, the exudative, which we have already gone through in the picture, okay? It's the same as this. So you have the serous stage, the exudative stage, then you have the fibropurulent stage, and then the organizational pass. That is all. Thank you.